So much for having me. I appreciate it, and I appreciate you allowing us to reschedule after last week. I am Nicole Alessi. I'm a residency trained optometrist at Collins Vision. I've been here about 8 years, and I manage a fair amount of glaucoma. I am not, however, a glaucoma specialist. I am a primary eye care doctor, but I do want to run through a little today about glaucoma and what it is, because I hear all the time from my patients that they're just not sure what we're talking about, which is very reasonable because this is a fairly complex disease process in the tiny little eyeball structure. So glaucoma is caused when pressure builds up in the eye and causes damage to the optic nerve. The optic nerve is the superhighway of information from our eyeball to our brain, and through that, all of the information is transmitted. It is a serious disease process because it causes permanent vision loss, and it is, in fact, the second leading cause of blindness in the world. So where does it occur? Glaucoma occurs at the level of the optic nerve. And as I said, it's that highway of information from the eye. It collects all the information from our retina and transmits it to our brain to be interpreted. The optic nerve plugs into the back of the eye and it looks like a donut. There is a cakey part. Can they see my? Okay, there is a cakey part of nerve tissue and there is a donut hole in the center. And we can see a healthy optic nerve here. When glaucoma begins to damage the optic nerve, it eats away at the cakey part and you start to lose that pink tissue. And in this case, you can see that it's mostly donut hole, not a lot of donut. And through the center of that donut hole run vessels, arteries, and veins that nourish our retina. As glaucoma eats away at that optic nerve, it steals our vision. So our job is to detect the change early and to stop it in its tracks. So what does glaucoma do to your vision? Well, glaucoma is very sneaky. It doesn't affect your vision in a way that you would immediately notice, especially in early and moderate glaucoma. An end-stage glaucoma, as you can see on the images on the right, it will completely and absolutely take away your peripheral vision. But in early stage, it's not a blackout of peripheral vision. It's a very slow decrease in the clarity and quality of your peripheral vision in a way that you will not know is happening. So it's really our job through a series of tests, and here you can see a normal test here, a visual field test, which is testing your peripheral vision compared to a visual field with glaucoma. And in this case, they're losing some superior field, and that patient wouldn't notice that in their vision. Frequently, one eye is worse than the other, so the other eye will compensate for that change. The 4 primary types of glaucoma that we will talk about today all have to do with the drainage system. And the drainage system in glaucoma is primarily how we classify it. So there's open angle glaucoma, angle referring to the drainage system, and we'll look at an image of that in a minute. Narrow or closed angle glaucoma, which can actually be an emergency situation, pigment dispersion glaucoma, and something called pseudo exfoliation. So I will go through all of these, and we'll start with the most common type. Glaucoma in open angle scenarios, and all of us should have open angles, the fluid drains out of something called the angle. That's our drainage system in the eye. It is where the white part of the eye that I'm pointing at here, the sclera, meets with the clear window on the front, the cornea, and it also meets with the iris. This is a cross section of the eye. So you can see the pink structure here, or on the blow up here, is the iris, the colored portion of your eye. And where these structures meet, it forms this narrower angle. This opening can actually slowly become more narrow with time. It can change shape, and the fluid dynamics can change. In the blow up here, the fluid would flow out the angle into something called the trabecular meshwork, which is the drainage system of our eye. So as new fluid is constantly being produced, it flows around the lens, either lens implant if you've had cataract surgery, or natural lens in our eye into the front of the eye and out the drain. The trabecular meshwork, this meshwork that the fluid flows through, provides resistance to the fluid's outflow. And as it provides that resistance, if over time the meshwork changes density or shape, or if your fluid dynamics change, even when that drainage system is open, fluid can begin to back up in the eye. And as fluid backs up, pressure builds and it damages that optic nerve. So an open-angled glaucoma, there typically actually isn't a sudden increase in pressure in the eye. There typically is a very gradual increase that your doctor will notice over time. And sometimes the pressure that you've always had, sometimes your pressure stays the same, becomes too high for your tissue. And that is because our tissue becomes more delicate with time. So because of the new fragility of our tissue with age, if you've always had a normal pressure, sometimes that normal pressure becomes too high for your tissue. And we see open angle glaucoma occur. Now, if that angle were to close and completely block the drain, we would have a medical emergency. This is one of the few times where you would actually have a symptom in glaucoma, and that would be very blurry vision, a red eye, headache, nausea. In fact, many patients in angle closure will go to the emergency room because they're vomiting. And the emergency room may think there's something wrong with the GI system, but it's really all due to a buildup, an extreme buildup of pressure in the eye. The average person cannot detect pressure under 50, which is a very, very high pressure for the eye. But after that point, you can start to have these symptoms in angle closure. Most people don't ever feel the pressure building in their eye unless there's an acute and serious situation like this. And we'll talk about the treatments of narrow angle glaucoma or angle closure glaucoma in a moment. The third type of the most common forms of glaucoma is called pigment dispersion. So in this image, the arrow is pointing to pigment that is deposited on the cornea in a vertical shape, and that's due to the fluid dynamics in the eye. That's how it deposits. That pigment is released from the iris, the colored portion of your eye, and it doesn't matter what color your eyes are, this can become a problem. Typically, this becomes a problem either due to the zonules in the eye, the cataract in the eye, a dislocated cataract implant, but it releases the pigment. And the pigment doesn't just deposit on the cornea, it deposits in that drainage system that we talked about, clogging it up, which causes fluid to drain slower, pressure to increase, and glaucomatous damage to occur. The third type of glaucoma, the fourth type of glaucoma and final type that we'll talk about today is pseudo exfoliation. In this picture, you can see the hazel colored iris on the outside. In the middle, you're looking at the natural lens of the eye, and you can see this almost bullseye pattern of tissue peeling up. That tissue is the capsule, the bag that holds our natural lens. And when the lens rubs against the iris, it releases that tissue in flakes. And again, can clog up our drainage system. So just a different way to have a clog. But patients with pseudo exfoliation, which is what this is called, where that capsular tissue flakes off and clogs up the drain, the only fix for this to stop the process is cataract surgery. It's not immediately an emergency because this is a slower process, as is all glaucoma. It is the tortoise, not the hare, but that is the best way to fix it. And we'll go over that because that removes that tissue and the lens that's pushing on the iris and puts all the anatomy back into place. So testing for glaucoma. And every time you have even a general eye exam, we check the pressure in the eye every time. Sometimes they do it with an air puff. Not the most accurate, but it does give us a general idea. Sometimes they use a blue light. We want to make sure that your pressure is in what's called normal range, generally between 10 and 20. We also want to make sure that it's about the same between the two eyes, that there's not a tremendous difference in the pressure between the two eyes. And finally, that there hasn't been a major change from previous years. With glaucoma, knowing your history, what your numbers have been and what your optic nerves have looked like in the past is very important. Additionally, we dilate the eyes and we look at the nerve. And the doctor picking up on changes in the optic nerve or abnormal shapes in the optic nerve is one of the major ways glaucoma is detected. Once glaucoma is detected, or the suspicion of it, we do some additional testing. We look at the thickness of the cornea. I think of that, I relate it to tire pressure. If your cornea is very thick, like the tire on a semi-truck, and we try to indent it with a little bit of pressure to find out how much force is resisting us, that very thick cornea will not indent very easily. So thicker corneas actually protect against glaucoma. Thinner corneas indent very easily, and that actually means that you're at higher risk of having glaucoma or perhaps glaucoma progressing. In addition to taking corneal thickness, or what we're calling pachymetry here, into account, we measure the tissue of the optic nerve itself with something called ocular coherence tomography, or OCT. This is a test that if you have glaucoma, typically you will have every year, and we're looking for change. Glaucoma will eat away at that donut, that cakey part of the donut, in a very specific pattern. Sometimes you're just born with a large donut hole, just like some people have big noses or big ears. This test will tell us, is the enlargement of your optic nerve normal, or is there thinning associated in the pattern of glaucoma? And finally, we look at that peripheral vision. We do the visual field test. And that visual field test, it'll show us neurologic damage, it'll show us glaucomatous damage, but we want that glaucomatous damage or that change in the vision to correlate to the other tests, the other images that we've taken, for example, that OCT. So they should all match up. So I like to say, even when you're suspicious, glaucoma is slow, we have time to do all of the testing and really make sure that we're appropriately diagnosing it before we dive into treatment. So let's dive into treatment. There are many, many ways to treat glaucoma, and that is a decision you will make with your doctor. If you have early detected, very mild glaucoma, typically we can start simply with prescription eye drops that you would use anywhere from 1 to 3 times a day. If you are not a person who could be compliant with eye drops, I know we all forget and we have lives, there are also laser options. And if, for example, you had narrow or closed angle glaucoma, the picture on the left, you can see that there's a little hole poked called an iridotomy in the iris. That creates an escape hatch for the fluid back to the back of the eye so that the fluid doesn't build up in that angle closure. And that is a treatment for narrow or closed angle glaucoma. If you have open angle glaucoma or any of the other glaucomas, the other laser options are either a selective laser trabeculoplasty or an argon laser trabeculoplasty, an SLT or an ALT. Those lasers are aimed at the drainage system and they blast through that meshwork, opening it up so fluid can flow out more readily. The ALT typically creates a bit more scarring, so it's not something we do over and over. The SLT is a little, we can call it a gentler laser. It opens the tissue up without creating the scarring, and it can actually be repeated a number of times. In cases of pigment dispersion or pseudo exfoliation, those last two that we talked about, frequently the culprit is the cataract. And in those cases, cataract surgery is the way to treat this problem. And I use the word treat, not cure, because regardless of the type of glaucoma, glaucoma is not a disease with a cure. It is something that is treatable and manageable, but you will have to stay on top of once you're diagnosed with it. It doesn't go away. With cataract surgery, when we remove the lens, in those last two, pigment dispersion and pseudo exfoliation, we remove the offending agent. No more pigment or flakes of tissue will be released into the eye. Now, what's already been released and what's clogging up the drain is still there, so we have to continue to watch the pressure. In open angle glaucoma, during cataract surgery, we can also do a combined procedure where we can either do a laser or insert a tiny little stent, and you can see a picture of it here, into the drainage system. And the stent, the little micro tube, has no resistance to the outflow of fluid. So placing that into the meshwork allows fluid to escape more readily. It works just beautifully. So lots of different treatment options. In severe glaucoma, advanced glaucoma, there are also some pretty significant glaucoma surgeries where they will go into the eye, put a tube shunt in, create a drainage port, etc. And those are things that we refer to glaucoma specialists, and we do have several here in town. So just to finish up, I know we touched on cataract surgery a bit. This is a quick, easy procedure, 6 to 10 minute outpatient procedure, even with the addition of the combined glaucoma procedure. It is safe, fast, comfortable, can correct your vision, and reduce the risk of glaucomatous progression. So that about sums up my general discussion of glaucoma. I would love to answer some questions.
Speaking of medical history, if one has high blood pressure, is that another risk factor for glaucoma?
So while it can affect blood flow to the optic nerve, it does not affect pressure. The blood system is separated from the cerebral spinal fluid by what's called the blood-brain barrier. And our eye is continuous with our brain and our spine. So the eye is actually protected from changes in blood flow by that blood-brain barrier. So high blood pressure does not necessarily put you at risk for glaucoma.
Okay.
If you have glaucoma, we would want you to have that controlled so that your at-risk optic nerve is getting appropriate nutrition.
Absolutely. All right. And earlier you talked about the drops and how those are used to relieve the pressure, but can you go into a little bit more detail and explain again how those drops do indeed relieve the pressure?
Sure. There's several different classes of eye drop, and within each class, they work a little bit differently. So there are drops, and I won't go into too specifics because it gets a little complicated, but there are drops that will cause the drainage system to open and increase outflow. So it kind of dilates the angle a little bit. There are drops that reduce the amount of fluid being produced so that there's less fluid, therefore pressure is lowered. And those are the two primary causes. And there's a lot of classes that work within those actions, either reducing the amount of pressure, reducing the amount of fluid or increasing the outflow. And some of them work in combined option like that.
And if someone is using those drops, is at a short-term treatment, or will that last basically for the entirety of their life?
If their pressure is elevated just for a short term, perhaps secondary to a steroid injection for painful arthritis, we would use them short term. If we're treating glaucoma, that's a forever treatment. Now, like anything, and this is the part of the reason there's no cure, we adapt to medications that are put into our body consistently. So we will find that after years of use, the drop that's always worked well is just not working as well. And sometimes we have to add a second or change drops.
Okay. And does our anatomy make a difference? If somebody has an astigmatism or there are other differences, does that affect or increase or decrease risk of glaucoma?
People with very short eyes, hyperopic or far-sighted eyes, that anatomy can change the structure of your drainage system and put you at higher risk of glaucoma. People with long eyes, obviously they'll have more space for that drain to be open, and those would be very nearsighted people. Astigmatism, but the actual prescription, the number, no. It's just the length of the eye, the axial length of the eye that makes the difference. So being nearsighted, farsighted, or having astigmatism will not make you more at risk for glaucoma.
Thank you. All right, I've got another question. Just bear with me on the pronunciation here, okay? So we've got someone that's currently in the early stages of the latanoprost eye drop washout. How often should they have their eye pressure tested in the first year? And then what other considerations do they need to be concerned of?
So latanoprost is a fantastic drug. It's a prostaglandin analog that reduces the pressure. It's one of the best on the market, that prostaglandin class at reducing the pressure, and it's dosed at only once a day, so it's very convenient. It's important to be very consistent with the drop. Use it at the same time every day at bedtime. And that really depends on the severity of the glaucoma that we're finding. If we're finding very early change with no vision loss, typically I will put a patient on a drop. I will check them about 6 weeks later, let it come up to effective dose in the body. And that could be 4 weeks, 6 weeks, 2 months. It depends on the doctor and their comfort level with your level of glaucoma. And then for the first year, I would probably keep an eye on you at every 3 to 4 months to make sure that it continues to work. Long term, my glaucoma patients don't come in less than twice a year. Going longer than that does put you at risk of some progression that's going unchecked. And we can't get back vision that you lose during those periods. So at least twice a year.
All right, so since we're talking about the latanoprost, actually I've got two questions. So the first one is, do you mind spelling the correct spelling for that drug? And
sure.
Then go ahead and do that, and then I'll go into what someone else is asking about that drug.
It's Latanaprost.
Okay. Who knew that it was going to be a spelling bee? All right. And so then another person is saying that they are also using those drops, 1 drop per day. And it seems that now they have a white substance that is coming from their eye. Is this normal?
Latanoprost is not in suspension. It is a liquid form drop. So it may be an allergy to the drop. It may be a low-grade allergy. It may be that the chemical is causing some dryness. So the eye itself is producing some mucus to moisten it. And that would be something that I'd run by the doctor. I would also say, though, that it's not worth stopping the drop. Continue the drop and have it checked while you're still on it. Pressure running too high is much more serious than having some discharge.
This must be a very popular medication, or a lot of our participants today are currently using. So I think back on the same topic, this individual they're using the drops, but those drops change to crust. How does that help?
The drops change to crust?
That's what it says here. My drops change to crust. How does that help?
I don't think I understand. If the bottle is old, perhaps they can get a bit dry and crusty around the lid. But I'm not sure I understand what's happening there.
If that is the case, and I'll have her pop in if it's different. But if they do find that it is getting crusty around the bottle, is it time to discard and get a new prescription?
Yeah, check your expiration date. Make sure that it's good. You know, you don't want to leave your drops in the car. You don't want to touch the bottle to your eye when you use them. You want to do everything you can to keep that top sanitary. Now, of course, the vehicle is going to have sterile saline and preservative in it. And if it's just sitting on the bottle, it will dry out and, you'll get some debris there. And I wouldn't want that in my eye. It's debris.
Gotcha.
It's free to wipe the top off with an alcohol swab, something like that.
Okay. Next question has to do with the pressures. Their specific pressures are 14. Do they still need MLT?
I'm not sure what an MLT
okay.
is.
I'm not either.
SLT, maybe the laser.
Alvin and Yvonne, I'm going to let you guys, if I'm botching up your questions, feel free to write them in, and maybe we'll ask them here in a bit.
To that point, if you have glaucoma, what is considered a normal pressure may not be normal for you. Your tissue is more delicate, and therefore, just because the numbers are good or stable doesn't mean that sometimes you don't need further intervention. I have plenty of patients that live in the mid-teens for years, and then suddenly we start to see a little bit of progression, and now they need to run at 10. Or if they're off, so we need to do something, a laser treatment, another eye drop, or even though you've been stable for years, coming off that drop would mean that you would then spike back up into the danger zone.
Okay, Perfect. We still have the chat box going like crazy. So we've got more questions and I'm going to continue to throw them at you. And I just want to say how great everyone is. You're writing in, submitting some great questions. So keep at it. Okay, the next question, if I have laser surgery, my pressure drops as it should. Will the pressure now remain low, or is there a chance of needing further laser surgery?
There is a chance. So I have seen lasers last anywhere from 6 weeks to probably 15, 16 years where we don't need to do anything. And it depends, A, on the kind of laser that you've had, and B, on your body's tissue. Because your body will be very slowly, albeit working to heal what we did with the laser, which means eventually your pressure may drive back up.
Okay. Next question. I love this question. It's great. This individual lives alone. Okay. So let's say there is an event that they're hospitalized. Okay. What is the best way to communicate to the hospital for the continuation of those drops if they are unable to communicate?
Just like anything else, there are med alerts that you can have on file. So putting glaucoma as one of them is certainly reasonable. Now, if you are hospitalized and non-communicative, your glaucoma is probably the least of your worries. And as I have said, glaucoma is a very slow moving disease process. So the likelihood that something would tremendously change in the week, 2 weeks, month, or 2 months while you're being treated and not able to communicate is actually unlikely. It's when we get into longer time frames going unchecked that it becomes a problem. So I don't think that needs to be high on your list of fears or priorities unless you are end stage glaucoma with very little vision left and we really need to protect it, in which case, just like a diabetic or anything else, I'd set up a med alert.
Yeah, good, but great thinking. It's always good to think ahead. You just, always have a plan. So let's go back to the question from earlier about the drops turning to crust. And maybe that was meaning the drops were then turning to crust in the eyes. So this one, they're stating that it's a new bottle of drops, but it ends up being a thick white residue.
If they use them at bedtime, they're waking up perhaps with that thick white residue in their eyes. So then I would really wonder if you're having an allergic reaction to the drop. Not that that is severe. Allergies can just be itching or the production of mucus. And, we have to then debate, is this bothersome? Is it blurring your vision? Is it changing your lifestyle versus the benefit of the pressure lowering effect? Should we change the drops or do a laser? But please don't just stop them. And I do have this issue. There are patients that, just don't do well with the drops for any number of reasons, and we'll go to a laser treatment or explore other drop options.
Okay, thank you for clarifying. Next question has to do with the visual field test. Is there a gold standard test when you get that visual field test?
So the visual field is technically the standard of care for managing glaucoma, and has been as long as eye doctors have been around, because that is the actual true measure of how the glaucoma is affecting your vision. The reality, though, is that technology has changed tremendously. So that should not be the only test you have done. Measuring the nerve fiber layer, all the nerve fibers that make up your optic nerve, looking for that pattern change, measuring the ganglion cell layer that makes up the nerve fiber layer. These are the ways we actually stay ahead of glaucoma. So while the standard of care being the visual field, and it is a long and miserable test, while the standard of care hasn't changed, we do also have objective measures to look into and actually measure the structures of the eye to see if anything is changing. If a patient were unable to do the visual field because of neck pain, or honestly, they're just tired and they have dry eyes and they blink too much, if they fail the visual field a certain number of times, we move on to objective only testing. We don't keep torturing them with that.
All right. Okay. So earlier we talked about the latanoprost. Can you compare and contrast that to timolol maleate? And again, please forgive my pronunciation.
Timolol has been around forever. Latanoprost is the generic of a prostaglandin analog. They do work a little bit differently. Timolol is a beta blocker, and it reduces the way fluid runs through, it reduces your fluid production. The prostaglandin works both ways. They actually work fabulously in conjunction. So I have many patients that are on both the timolol and the latanoprost, or both timolol and brimonidine or Alphagan, and we're just kind of comparing and contrasting generic and branded names there.
Okay, and I'm going to circle back to, okay, remember we were saying my pressures are 14, do I still need MLT? And as I go down here, they told us what the MLT meant, and it was micropulse laser
trabeculoplasty.
Okay,
so yes, MLT, so again, I would say, so excellent question and great procedure, works really well to lower the pressure in the eye. And if your pressures are 14, without knowing what your optic nerve or visual field looks like, if you've shown any sign of progression at a 14, then yes, I would have the procedure to go lower. If you're stable at 14 and there's no progression of the glaucoma at 14, which is all that testing that your doctor looks at, then I don't imagine that they would be recommending another treatment.
All right, thank you for clarification there. And then can you circle back again to the connection between cataract removal and at the same time relieving the pressure on the eye?
Sure. By nature of cataract surgery, your cataract, it grows in your natural lens. The lens is the structure that allows us to focus from one end of the football field to the end of our nose when we're 8 years old. And with time, it becomes opaque and stiff so that it doesn't flex anymore. It doesn't allow us to see up close as well. We start to need the reading glasses. And as we lose that vision and that lens becomes more thick and dense and opaque, it takes up more space in the eye. It can actually drive the pressure up very slowly with time, which is a trend we do sometimes see. That doesn't mean it's causing glaucoma. In an otherwise healthy eye, it doesn't necessarily cause glaucoma. When we remove the cataract, we put an implant in that is 1/16 the size of that cataract. So we're creating a lot more space within the eye. The angle is then able to be more open. So just by nature of cataract surgery, without doing a combined procedure, we do tend to lower the pressure a point or two in the eye. Additionally, we can do a combined procedure. So at the point where the cataract has been removed and before the implant is put in, they can apply a laser, this is one option, to the fluid producing body called the ciliary body in the eye. And that would allow that body to produce less fluid, thereby bringing down the pressure. Your body will heal that slowly with time, just like it does with every other treatment that we have at this point. The other option is to insert this micro tube called an eye stent into the drainage system. And the drainage system, as I said, it's a meshwork. There's a lot of resistance there, but putting the tube through that meshwork and allowing a port of no resistance to outflow where that fluid can flow freely, again, brings the pressure down. So the nature of the process, just cataract surgery on its own will lower it a little. If you have glaucoma, a combined procedure will even further lower the pressure.
Okay, good. And are there any long-term issues with being on latanoprost or any of these medications for a long period of time? And are there any contraindications to that?
There's contraindications to almost every one of them. Okay. Sulfa allergies, different things for these different drugs. So your doctor will go through your medical history, go through your allergies before they put you on anything. It's not arbitrary, these decisions. Additionally, long-term effects, latanoprost, the prostaglandins, which is Xalatan, Lumican, Travatan, and then it's generic, which is latanoprost, they can cause a darkening around the lid margin. They can also cause a slow eye color change. So we wouldn't see that in a brown-eyed patient. We might maybe see it in a light blue-eyed patient, but it is rare. And then the very worst side effect is that the prostaglandins actually make your eyelashes grow very long.
Oh, there you go. Ladies, no need for mascara, right? Going back to the MLT that you were speaking about earlier, is that good for only about 2 years?
That it depends on your anatomy. I've seen patients rebound very quickly with high pressure. I've seen patients last for several years, which is average. But, I would say, 1 to 5 years is average for a laser treatment for glaucoma. So it's in the same ballpark, but it does work well.
Okay, perfect. All right, the chat box and the Q&A are kind of calming down a little bit. Just to give me a few minutes to go through, I want to go through the chat box and the Q&A one more time because so many questions were coming in and I wouldn't want to miss one of that. But while I'm going through that box, Dr. Alessi, can you tell us a little bit just more about your practice, how someone could get a hold of you, schedule an appointment? What I love, you're not just there's the medical basis behind what you're doing. So if you could just give us a little more info about how maybe we could get in touch, schedule an appointment.
Sure. We currently have 3 doctors. Our surgeon, Dr. Collins, specializes in cornea, cataract, refractive vision concerns. So really giving you the best possible vision for cataract surgery. He does do SLT laser for glaucoma, the combined glaucoma procedure with the eye stent, and manages a lot of disease, things along those lines. Dr. Rosen, my counterpart, and I are both residency trained optometrists. So we did a year of extra education really to work primarily with surgeons and at the medical end of the spectrum. We still do complete routine medical eye exams. We fit contacts, but everybody is screened for the disease, for the macular degeneration, for the glaucoma, for any problems. My specialty is dry eye. That is my wheelhouse, and I really enjoy getting into it with my patients because it's something that I suffered from. So I like to see them get some relief. Dr. Rosen does amazing specialty contact lens fits. So patients with keratoconus and all kinds of corneal problems, he's able to put them into specialty lenses and give them back vision. And our office is super easy to get into. Just give us a call. I believe our phone number is on this page, and if not, we'll put it out there. But we will get you in and give you a full once over and make a plan.
All right, thank you. Another question did pop up. We threw in the allergies. So you mentioned the sulfa allergy. Can you say a little bit more about that and how it?
Well, all of them. So sulfa is one specifically with the prostaglandins. If you have a reduced respiratory rate, we'd be very careful with a beta blocker like the timolol. We will kind of run through. Now, these are not anaphylactic hospital-like allergies to medications. This would be a red irritated eye, burning, itching, something like that. So nothing that you need to worry. It's not going to kill you. It's going to make you a little bit uncomfortable. But again, usually reducing the pressure is more important in the grand scheme than that discomfort. And of course, we take you off what didn't work for you, or if you did have an allergy to something and try something different. There is trial and error there, but keeping that pressure down and being consistent with the drops is the most important thing.
Okay. And what are optic pits, and how does that relate to glaucoma?
Optic pits typically are congenital, and they're an excavation of the optic nerve that sometimes are mistaken for glaucoma. Because there is less tissue, it does create a bit of a wrinkle in the testing. So frequently, if you have an optic pit, that standard testing that we look at and the patterns we look for are going to be different in you because your anatomy is different. So we just have to be able to take your anatomy and remove what we expect based on your special optic pit anatomy and look for the glaucomatous change within that. It would be, for example, a patient who's lost vision due to a stroke, which is a really specific vision loss. You can still have glaucomatous vision loss. You're not going to see it where the vision loss from the stroke is, but you have to look at the rest of the picture. So it can increase the risk of glaucoma in that you have a bit less tissue. So we have to be very cautious and make sure nothing's coming of it. But it is just, in fact, an excavation of that tissue at the optic nerve. It looks like someone took a melon baller to the optic nerve.
So for the cataract surgery removal and these other procedures, are they being done in your office, or do you need to go to a hospital or an outpatient
They're not
facility?
hospital based. At Collins Vision, and I'll also see most of the eye doctors in the area, they have satellite surgery centers that are very specific to eye surgery. So we have St. Mark's, it's about a quarter mile from our office on the same street, and they specialize just in eyes and maybe some facial plastics, lid surgeries, things like that. But retina specialists, cataract surgeries, glaucoma surgeries, things along those lines. But not hospital based. You shouldn't need to go to a hospital for cataract surgery or glaucoma surgery.
Okay. And just to kind of touch on that point, these types of surgeries, if it's done, if there is something that they can do in the office, is that covered? OHIP is what they said, but I mean, can you talk about the insurance coverage that you guys all offer?
I can talk generally. Insurance is a bit out of my wheelhouse, but what they do, but glaucoma is a medical diagnosis. And any treatment for glaucoma should be covered by insurance. Now, there's always going to be blips, and some they'll want you to try the generic before they let you have the brand, or they'll, want proof of X, Y, and Z before we can do a procedure. But that's common. It is still a covered procedure, and of course, we're not doing things on patients that aren't necessary. We're not going to recommend lasers, micropulse, eye stents unless there's clear evidence that glaucoma is there.
And floaters, can floaters be a result of glaucoma due to decreased filtration?
No. Floaters are one of a couple things, either accumulations of protein and macronutrients in your vitreous, the gel in the back of the eye that kind of float around, or the bigger, more permanent kind of floater called a vitreous detachment that everyone really gets at some point. But that is in the vitreous, that is in the back of the eye, and it does not have an impact on glaucoma. They're not caused by glaucoma, and they aren't exacerbated by glaucoma.
All right, we got another one coming in. So I have to say this is a very knowledgeable group. One of the best chat Q&A sessions I think we've had. So this individual has been told that a compass, I think it's a VH test, is good because it includes a picture of the optic nerve. Is this correct? VH test, sorry, my
visual field test.
Yeah.
So there are a lot of different visual field tests. I'm not necessarily familiar with all of them. They all do the same thing, but the imaging they take during the test may vary. So we do absolutely want an image of the optic nerve. We want a photograph of it because we want to be able to compare how it looks year to year. So when I'm looking at your optic nerve, I want to look at last year's picture and make sure there isn't change. We want a scan of it where we're actually measuring the tissue. That's the OCT, the ocular coherence tomography. And then we want that visual field. And there are machines that do multiple steps in one. And so some of our lens crafters, doctors, and things like that will often have multiple steps in one so that they can use it as a screener to make sure that they're not missing anything. Especially because there's not a lot of repeats to some of those doctors. They want to make sure they catch everything they can in that environment.
Perfect. Well, Dr. Alessi, actually, this comment that came in from Darlene, it's just perfect. She says, "Thank you. This was a fantastic presentation." So I just want to bring attention to her comment and echo that on behalf of the Healthy Life Center. So Dr. Alessi, thank you for spending the time today. Thank you for answering all of those questions. We threw a lot at you today. So again, on behalf of the Healthy Life Center, thank you, and thank you for your partnership. To everyone that's out there, I'm going to send a survey email. If you would kindly fill that out, provide us your feedback, any topics of interest that you are interested in, let us know. We really appreciate the partnership with Collins Vision. They do a phenomenal job educating. So let us know what you're looking for, and we would be happy to set something up there. Let's see, I've got a lot of thanks. This is great. So again, we just want to thank you so much, Dr. Alessi. If you have questions or concerns and want to get a hold of Collins Vision, as she said, go ahead, give them a call, or feel free to reach out to us. We would be happy to be that intermediary and get you in contact. Also, if you need a primary care doctor, it's just important to make sure that you're taking care of your overall health. Don't hesitate to reach out to us, and we would be happy to connect you with a primary care physician here in the area. So with that, Dr. Alessi, enjoy the rest of your day. I know you're probably getting back to that patient load, so hopefully we can give you 10 minutes back of your time, and we look forward to partnering again. And just thank you to everyone out there for joining us this afternoon. So get out there, enjoy the day, maybe get a little activity, and have a healthy day. Take care, guys. We'll see you next time.
Thank you so much.
Thanks, Dr. Alessi. You're awesome.
Thank you so much. That was great. They were wonderful questions.
They were great. Yeah. All right. So please tell Stephanie thank you. We have a big box of Frisbees. So
Yes.
if there's any way we can get them to you, I'm happy to, even if you want to drop them by, I'm happy to do that.
I can definitely come by tomorrow. I will
Okay.
finally be able to escape the building.
Okay, it is no rush. We're not going to keep them hostage or anything, but we just want to make sure that you get back. All right, guys, as always,
Thank you so much.
We'll see you soon. Bye.
Bye.
Bye-bye.